Actually, I'm cardiac surgeon in Medina Cardiac Center, and thank you for your invitation because uh, I think it's pleasure to talk to a group who is all interested in cardiac surgery and particularly pediatric cardiac surgery, which is my passion. Um, the topic given to me was total anomalous pulmonary venous connection, and I will try to focus more on the clinical aspects because most of the things you can um, you can read yourself, uh, things like classifications or whatever. I think it should be an interactive session and you welcome to ask questions, but please ask questions in English. I have not read it in Arabic. Right. So like usual, to understand a congenital heart defect, we need to have some understanding of the embryology. Embryology of both how the things develop normally and when something goes wrong in the development, then we get this congenital heart disease. That's, I mean, obvious. I will not go into very many details, but very early in the embryonic life, around day 27, the lung bud starts to develop, and outside the lung buds is a splanchnic plexus of veins. And those veins, they join actually systemic veins, as you can see. And in the course of development, these splanchnic veins get incorporated into the developing lung buds, and like they form the plexus around the alveoli, and they lose their connection with the systemic veins. And as we all know, the systemic veins, which are cardinal veins and umbilical veins, they ultimately join one sinus vein, which drains to the atrium, which is initially common, but then they, with the septation and whatever, they shift more toward the right side. So the systemic veins mostly go to the right side, and the pulmonary veins, they develop with, obviously, it's not developed like one process of involution or progression of one structure. They meet the developing buds from the left atrium, and initially this one canal, and this it this connection goes up to here, and then we end up with a situation where we have four openings, or somewhere around four openings of all of the pulmonary veins going to the left atrium. Now, if this is arrested at any point in their development or is malformed, then it can give rise to the three topics which you have chosen today: partial anomalous pulmonary veins, total anomalous pulmonary veins, and something called core titratum, which I think somebody is going to talk to you later. I'm sure you will see these slides again. So familiarize yourself a little bit with the developmental anatomy. Sometimes it's and some people are fond of asking it in the exams, and also it adds to your understanding of the subject as a whole. So we skip to the next thing: is how much is the incidence? Um, Almost 1% is said is the incidence. We kept our database in Medina Cardiac Center, and we found that in our surgical database it's 1.7%, which is around about the same. But there's also familial clustering, which suggests autosomal dominant inheritance, and it's also part of some of the syndromes. And actually, there's been one identified gene, chromosome, uh, connected to the total anomalous pulmonary receptor. Uh, so, like I said in the beginning, if you have some idea of the development, you can imagine that all combinations are possible. One of the combination is that three veins go to the left atrium, but one goes somewhere else. In this cartoon, it seems to be going up, but actually most of the time it goes down, which you understand as a part of a scimitar syndrome. And sometimes the whole lung, one lung may go up anomalously, and while the other lung is connected normally. These are some variants of, I would say, partial anomalous pulmonary venous return. Total will be when all of them they join and then they go somewhere not to the left atrium. So that's how their anomalous drainage. And the anomalous drainage can go in different directions. But when they all connect anomalously, when they're all draining abnormally, then they usually go together. They end up in one anatomical structure together. And this is that famous Darling classification, and I like it because easy, and it actually conveys a lot about the anatomy of the lesion. So if easy to remember that all veins go and join supracardiac, and incidence is 45%. I put in the red the MCC data because in our database the incidence seems to be like a little bit different, not very much different except for the infracardiac ones. And the cardiac ones, which all veins join together and drain in cardiac cardiac structure, usually into the right side of the heart through the coronary sinus. That's about 25%, and we see here in Medina about 39%. And then there is a mixed variety where infracardiac, the combined vein will go travel below the diaphragm and will join a systemic vein there. Sometimes part of hepatic, sometimes hepatic veins, or uh, the other gut veins, which are um, the part of the gut venous system. And they can be mixed. By mixed, we mean some of the veins going in one, joining in a supracardiac manner, and some going infracardiac, one or two going cardiac. So a mixed variety is also there. That makes this that's how this it makes this lesion quite interesting. Uh, uh, if I had to actually these quite a few of these slides I borrowed from my friend Mansoor Materi, who is an interventional cardiologist here, and he had some excellent pictures to show. So I thought I'll share with you. So this is the cartoon drawn that veins from the right side, veins from the left side, they join together into a common confluence. The confluence goes as an ascending or vertical vein up, which joins the innominate vein, where it is just where the left SVC is coming, and then this innominate vein goes to join the right superior vena cava and goes into the right atrium. So far, so good. So it has gone into the right atrium, but it has to go. Some part of it has to go to the left atrium. Otherwise, we'll have no cardiac output, no systemic output. So there's always a PFO or a stretched PFO or an ASD to allow the blood to go to the left side, and then the left side pumps this admixture of the blood into the systemic circulation. And as you can see in this angiogram very nicely, this is the confluence, the ascending or the vertical vein joining the innominate vein going to the right SVC, which appears larger. Actually, the innominate vein surgically will appear much larger when you open, and then it goes to the right atrium. And from the right atrium, some part of it has to go to the left side. Otherwise, there's no survival. But mostly there is PFO, or sometimes even more than a PFO. You could say stretched foramen, which has unobstructed flow going to the left side. This is the cadaver slide actually showing the same thing, ascending vein, innominate vein, and superior vena cava. Now, this is the X-ray which you are, I think maybe you are all familiar with, and so-called snowman appearance. As you can imagine that in the plain X-ray, you can see the, the bulging ascending vein. Then you see a more distended right superior vena cava. And so the upper part of this mediastinum appears like the head of the snowman, and the heart itself contributes to the body of the snowman. Um, if you live in Tabuk, you might have seen some snow and made some snowmen, which appears something like that. But a snowman appearance on the X-ray is kind of pathognomonic of uh,
We see
anomalous
we see
pulmonary.
desert men. No snowman.
No snowman. Yeah, but
Yeah.
imagine, try to imagine. Now, when they are cardiac, then they all join they have to join a confluence. When we are talking about the total anomalous pulmonary venous return, then all the right and left, they will join together, and this confluence will go to the coronary sinus, and from the coronary sinus again the same blood circulation uh, part or more part of it will go to part of this. I mean, the pulmonary venous return will go to the right ventricle, and the part will go to the left side through a foramen valve to be pumped to the systemic circulation. Now, this is rarely obstructed, but you cannot say it's never obstructed, because a persistent Thebesian vein on the mouth of this coronary sinus can make it obstructed. Now, the issue of obstruction is obstructed and unobstructed is the two words which you should remember, because this is how the pathophysiology of them behaves in the clinical situation, and what makes the difference between an emergency and a non-urgent case. An obstructed TAPVD is an emergency or urgent. A non-obstructed gives you some time to plan and think, and also plan with the family. The infracardiac is, again, the cartoon depicts is easier, that you have pulmonary veins on both sides. They join into a descending vein, which goes down and joins one of the superior mesenteric vein or uh, hepatic veins, and it goes descend through the esophageal orifice of the diaphragm, and can join a portal vein tributary or one of the hepatic vein tributary. And drainage to the IVC directly is very rare, but this is the most common variety to present as obstruction from the beginning. Uh, and the obstruction can be where it is egressing from the diaphragm and going down. And the second um kind of theory is that because of the hepatic veins and other veins in the intra-abdominal portion, they are not that distensible. They are in some of them are they have to go through a solid viscera, so the vein doesn't distend and allow for this extra blood to go easily, and causes some obstruction because of that. Uh, Now, I, if I understand, maybe you heard about this Scimitar syndrome in the previous session. Scimitar is not only partial anomalous pulmonary venous drainage, there are associated things with it, but basically you see this a shadow on the chest X-ray, which appears like a Turkish sword. Turkish sword is called Scimitar. Apparently, this used to be like that. So I have seen adult cardiologists present to you an ASD, and later turns out when you are struggling in the war that it's actually a scimitar. So be careful with uh, in some of the presentations, especially in if it's not coming from a pediatric cardiologist who has clearly defined it and seen it, because sometimes maybe they overlook it. And as a surgeon, then you have to face the music. And this is a very nice angiogram, again borrowed from Mansoor Materi, which is, you can see if in the levo phase this big vein all going down to the IVC and appearing like a Turkish sword. Is it clear? Can you see it all?
Yes.
Yeah,
Yeah.
this structure,
Yes.
and then going to the IVC, going to the heart, to the right atrium. So that's how it is in an angiogram. Now, if we think about the pathophysiology, uh, by now you must have understood that all systemic and pulmonary venous blood is returning to the right atrium, even if it's joining supra, infra, or intra or cardiac variety, or even mixed variety. All blood is not systemic, as well as pulmonary venous blood return is to the right side. But on the right side, it has to be an obligatory shunt via an ASD to the left side to support a systemic cardiac output. But you can imagine that when both systemic and pulmonary venous blood returns to the right side, so the right side is obviously getting more than its normal quota of blood volume, and it has to pump into the pulmonary artery. So that's how arterial pulmonary hypertension can be explained, and the dilatation of the right ventricle. But and ultimately developing high pulmonary blood pressure or pulmonary hypertension. But a more aggressive cause of pulmonary hypertension is the venous obstruction, which we will discuss a little bit more in detail. So I want you to understand that in a TAPVD, the obstruction can be contributed by the both arterial and venous side of the pulmonary system. This is actually, I just copied from the textbook of Marhudis, and I think this is a good slide to remember that the obstruction can not only be compression or volume overload, it can be intrinsic pulmonary vein stenosis. Pulmonary veins are quite notorious to have stenosis in them from the beginning, or sometimes after intervention, they get an accelerated some reaction of their intima and media and develop either isolated individual pulmonary vein stenosis or where they are all draining into some cardiac structure. Extrinsic compression, I will show you some very nice pictures, you will understand it better. The ascending vein, vertical vein, which is going in the commonest variety, which is the supracardiac, going up to join the SVC, gets compressed between the pulmonary artery and the bronchus. This is its course. It descends up with the pulmonary artery being medial to it and the bronchus being lateral to it. And that's where it gets compressed. Why it gets compressed? Initially, it may not be compressed, but in a few weeks, as the right side, I told you, is pumping more volume and the pulmonary artery pressure is getting higher, the pulmonary arteries start to become more dilated and bigger. And then they compress this vein laterally where the bronchus is. And so between that dilated left pulmonary artery and the bronchus, or the right pulmonary artery and the bronchus, it can get compressed. The other thing is a small esophageal hiatus in the infracardiac, which we alluded to earlier. As it's just descending down, it can be compressed at the level of the diaphragm. But remember, it can be combined intrinsic and extrinsic compressions. And then restrictive interatrial septum or trapezian valve, which we discussed, which we had a slide earlier. If on the coronary sinus orifice is obstructed, it will cause obstruction. And if there's interatrial communication, the ASD or the PFO gets narrower or is narrow, then that is a source of obstruction to the venous return, causing pulmonary venous hypertension. A cartoon will show it like that the pulmonary artery, there's a bronchus, and the vertical vein going up is being compressed between the two. But this angiogram, I think the CT angio shows it very nicely. The veins from the left side, the veins from the right side, they join this conference, and this is ascending vein. This is the pulmonary vein, and the bronchus is somewhere here outside. And as this is going to grow bigger, it's going to keep on compressing it and causing more and more pulmonary hypertension, pulmonary venous obstruction and hypertension. So the pathophysiology has divided it into like two types of presentations and two, I would say, clinical scenarios. If no obstruction, then it's only right atrial and right ventricular volume overload, and the child presents with some mild cyanosis. And this child can be, well, you cannot just sit on him forever, but you can follow him up for some weeks or maybe a few months, and plan his surgery accordingly with a regular follow-up. But if it's obstructed, then RV will be volume as well as pressure overloaded because it's pumping against a pulmonary edema, mostly due to the pulmonary venous congestion and increased PVR, and it will reduce the pulmonary blood flow. And these children actually in the extreme, in the one end of the spectrum, which is obstructed TAPVD in a neonate, that's an emergency, and they present in a very bad shape, severely cyanosed, very low cardiac output, almost in extremis. So it's very important to remember that there is, it can be TAPVD, but is it obstructed or not non-obstructed? That is going to decide the course of management and the urgency of the case. Again, the same story that if it's unobstructed, it's left to right shunt because the pulmonary venous return coming to the right side, and they can present like in congestive heart failure and mild cyanosis. Sometimes they're just picked as an ASD or something, and then people realize why the baby's cyanosed, and then further investigation with an echo proves that actually there's more than a small ASD there. If somebody shows you this X-ray of a neonate in the exam and says, this is a baby who presented as blue, you can see the congestion. And I say neonate because you can see the UVC, UV line there. Then almost is nothing else but obstructed TAPVC. And you can say that as your first answer, and most likely you will be right. And you can see the pulmonary venous congestion signs. All the lungs are congested, looking like a pulmonary, the like lymphedema-like picture in the lungs. Investigations, yes, we always start with the X-rays and ECGs, but an ECG is going to tell you right ventricular hypertrophy, right atrial hypertrophy, right axis deviation. But echo is the mainstay. Echo is basically not only because of its ease of availability everywhere and the logistics involved with it, but it's also almost definitive diagnosis. A good echo cardiologist, echo person can tell you almost all what you need to know about a TAPVC. Very rarely we have to resort to other modalities. But remember, if you're not sure, then ask for further investigations, other radiological imaging, so that the anatomical features are clear to you. So it can tell you the type, it can show you the way, it can tell you there's some obstruction, and where is the shunt, right to left shunt at the atrial level. Usually we find that, and dilated right side, and very squashed small left side, because left side is not getting its full volume which it should get from the pulmonary venous return. So it remains small. And as you know, the cardiac chamber growth and structural growth is related to the volume. If the volume doesn't pass through, they don't grow that well. Continuing on the same topic of investigation, yeah, TE may help you sometimes. But the next step would be cardiac CT and MRI. They give, in the centers where the expertise and the facilities available, they give you very nice images. You can play with them, you can rotate them around and look at them in whatever way you like. You can have a 3D reconstruction. Sometimes you having, for me, looking at a CT or MRI, nicely made image, also gives me a mental picture of how big the structures are and how to align your surgical incisions when actually you are performing the intracardiac repair. Cardiac catheterization, I would say rarely necessary, but if you are not sure, then cardiac catheterization can give you a definite evidence of is there an obstruction or not, and a very clear outline of the anatomy. And one thing which has been recently added in the last, I would say 10, 12 years, is some form of intervention where it can be done. And that is life-saving in certain situations. So this is how the echo will show you that you can see with the probe up, you see the vertical vein joining the innominate vein, and the innominate vein appears bigger. You can see a huge big SVC, and if you put a color on this, then that's how the color, the blood coming towards you on the vertical vein, and then going down again in the superior vena cava on the right side. But it can be other way around. This vertical vein can ascend on the right side and join the superior vena cava. It has happened a couple of times here in Medina as well. And if this is a very nice labeled slide, which I got from another colleague, which is, you see pulmonary veins on the left side, pulmonary veins on the right side, they go and join the confluence, and the confluence comes up as a vertical vein, and then innominate vein, SVC, and then you have evidence of some PDA here, and this is the flow in the aorta. So basically the echo, most of the time, will give you almost complete picture. But if you want, then they can do this type of imaging further with the CT and 3D reconstruction. and you can see the vertical vein going up, and the if I can stop it somewhere. Uh, uh, yeah, sorry. Anyway, this is the vertical vein, innominate vein, which is horizontal. Then on the left, on the right side, you see the right superior vena cava. This is the inferior vena cava, and they are both going to the right atrium. Again, we were talking about the echo. Echo will show you, as you can appreciate, a big right right side, big right atrium, big right ventricle, and it's almost squashed small left ventricle, and you can see a very rather smallish left atrial cavity, and that's exactly what you find in the operating room. You will find a very small left-sided structure, sometimes amazingly small, but they always work. Don't worry about the size of the ventricle in these kids. They just pick up the left ventricle, copes with it. This again from a slide from Mansoor, and he injected on the right side and on the left side. Focus first on the right side. You can see the vertical vein joining in the levo phase. Pulmonary artery injection, vertical vein going to the innominate and then going down the right superior vena cava. On the left side, the same story. Look at the levo phase, vertical vein joining the innominate vein and going to the right atrium via dilated right superior vena cava. Now, when we come to the management of these children, there is a medical management which is essentially hinges around diuretics. You treat the right ventricular volume overload with diuretics. I don't know about ACE inhibitors or whatever, but mainstay is diuretics. But surgery is a definitive treatment. And as I said, I keep on repeating it, that emergency surgery in cases of obstructed TAPVC. Actually, in my training in Boston, Richard Jonas used to teach us, and he used to say there are two pediatric cardiac emergencies, real emergencies. Number one, obstructed TAPVC, or neonatal, sorry, I'm not too pediatric, let's say neonatal or pediatric, whatever, obstructed TAPVC. And number two is a cath lab catastrophe. When somebody loses a device or whatever, we have to do it right now. So some of the TAPVC you have to do it the same day or night or whatever. But catheter intervention, which is now you see some reports in the literature, have actually taken some of this emergency hassle away from us. And we can plan a surgical correction later, and I will show you some examples later. So again, the same, I'm repeating myself, unobstructed, you can medically manage and plan a surgical correction. Now, planning a surgical correction in the congenital heart surgery doesn't only mean that you plan yourself. By yourself, I mean your OR or your scheduling, or you arrange for blood or talk to anesthesia. There's also a planning with the family. The mother may not be, herself may be sick and need 1 or 2 weeks or something. So the unobstructed ones, or they want to do it in school holidays after a month. So yeah, unobstructed ones, you can say, okay, fine. We'll watch this kid and we can do it later. But obstructed one will be either emergency or an urgent. And some of the very bad ones, who as a neonate present obstructed and their lungs are congested, as you saw the X-ray, and they get ventilated and hardly manage to have a PO2 in the ranges of 30s or 20s, and worsening general condition, including the systemic low systemic cardiac output, which with acidosis. So they have to be supported by ECMO preoperatively. And there are, I mean, people have done it, put the child on ECMO, stabilized him overnight, and took him to the OR the next day and repaired them on ECMO and brought them back on ECMO because they still have pulmonary hypertension. To this category has been added this thing of catheter-based stenting, which if possible can sometimes give you a breathing space, and you can do it in a better way. But remember, diagnosis of TAPVC is an indication for surgery. The surgery is indicated, obstructed or non-obstructed, it has to be done. Only the timing is different. Um, now we go to this. I will not go into smaller details of the bypass and whatever, but the easiest way is to perform a bicable incision starting from the, well, you have cannulated bicavally SVC and IVC, and the easiest way to form, sorry, not bicable, biatrial incision. So you start your incision at just below the right atrial appendage and keep going right up to the left atrial appendage, which is here somewhere, and open it widely. So the chambers will be open in front of you. You will have a right atrium in front of you with a coronary sinus, with a tricuspid valve here, with the interatrial septum with some PFO or communication between the two, a smallish left atrial chamber, and then the dark structures are the anomalous pulmonary veins from the right side, and from the left side you cannot see, joining into this is the confluence. So you open the confluence from one end to the other if it's lying parallel, and start suturing to this big anastomosis. Once you sutured with this big anastomosis, then you can close the rest of the atrial the left atrium. If you want to patch, you can enlarge a little bit and patch the PFO as well to provide more space in the left atrium. And then all this blood will go here towards the mitral valve and to the left side. This way, the anastomosis is usually quite wide and patent. You don't need to lift the. There are other methods of doing things. Yeah, remember in especially in pediatric cardiac surgery, there are more than one ways of doing it, a procedure. But I find this one works consistently. You don't need to lift the apex of the heart, and you can align the incision which you have made in the common chamber and the back of the left atrium very nicely. Because if it's not aligned properly or is twisted, the obstruction can be at the level of the anastomosis. The other thing which you would, if you read the books or literature, you will see something called sutureless anastomosis. And sutureless is basically you don't suture to the cut end, you suture away from the cut end, including some part of the pericardium, the atrial wall, so that you are not suturing directly to the wall of the pulmonary veins. Because I said earlier, the pulmonary veins, if you suture them or cut them, they have, in some cases, a propensity to react very rapidly with more fibrosis and thickening and ultimately stenosis. So this is the repair of the supracardiac TAPVC. There is some controversy. Should well, in my view, I have always ligated the ascending vertical vein, because if you don't ligate the ascending vertical vein and leave it as a pop-off, you will not get more flow going here. It will go towards maybe toward the lower pressure system. But people tend to leave it for the very same reason, that if there's severe pulmonary hypertension, if the lungs are very pressure in the pulmonary arterial system in the lungs is very high, then it acts as a pop-off. But I don't think that. Most of the surgeons I have talked to, they usually will ligate the ascending vertical vein.
Doctor, if you are concerned about pulmonary hypertension, isn't it more practical to just leave to ligate it and just leave a fenestration in the ASD, so you can close it later by catheterization?
Mostly we don't find it necessary, because the pulmonary hypertension management now, I will talk about it later, has improved a lot in the intensive care, and we hardly ever lose a child or somebody with a pulmonary hypertensive crisis. You understand what I'm saying? So
yeah, I understand.
Yeah, it can be dealt with. you can leave a pop-off, but pop-off will leave you still blue and maybe defeat your purpose. You want to direct as much volume to the left side as possible. So this is the rationale to ligate the ascending or vertical vein. And in cases where you develop is after doing this type of anastomosis, in not a very insignificant, actually about literature says about 13% may develop stenosis in usually where you have cut right up to the up to the not the confluence but back into the pulmonary veins, and that stenosis then you have to do, then you, if you have to redo it in those cases surgically, you have to go in the sutureless manner, that you incorporate, you use your suturing to the flap of the pericardium around the veins and not directly on the veins, and to enlarge it. This is another approach which is called Tucker's approach, which is a superior anastomosis of the TAPVC. If you allow me to go back, sorry, this one, you can see how much cutting is involved in the whole of the both atria. It's a biatrial incision, but here you don't cut the right atrium, and if it's aligning like that it is sitting right on top of the small left atrium, then you make an incision in the confluence and make an incision on the top of the left atrium and anastomose it as wide as possibly you can. And actually, one of the Indian centers has reported that they did almost 40 cases like this in supracardiac TAPVC, and they never faced a problem. And they think that the incidence of atrial arrhythmia is less in these cases because it involves less atrial incisions. But it is, again, when you open and you dissect everything and you see the confluence nicely, if it's sitting very close to the left atrium, go for it. Tucker's approach, easier. The surgically to deal with is the easiest one is the cardiac variety, where you have to actually, because they're draining into the coronary sinus and there is a PFO or foramen ovale or the septum there, you extend it toward that foramen ovale, make a bigger ASD, like you have opened it, taking care not to injure the inside wall of the coronary sinus, so to avoid the conduction system, and then put a bigger patch, correcting everything towards the left side, closing everything towards the left side, except for what is normal for the right side. Now, what is normal for the right side is SVC opening, IVC opening, and the tricuspid valve. And you can, don't worry about putting the coronary sinus on the left side. It will not cause a problem. Mostly, it doesn't cause a problem. And it's a easier approach and less risky, I think. In the mixed variety, then you'll have to, I think, you need more imaging and need to decide what you want to do. If only one vein is going anomalously somewhere, leave it alone. Don't make it a difficult operation for yourself. In some cases where two veins are going to the right atrium and the other are going somewhere to the coronary sinus, then you can reseptate the right atrium as well, like what you were saying, make a PFO, whatever, but cut the septum and put a patch so that they baffle to the left atrium. It is possible. Mixed varieties are usually very rare, but if there's only one vein, I think don't try to bother to make a long anastomosis somewhere or some very fancy baffling. Usually these things just complicate it. Now, the results used to be not very good in 80s and 70s and maybe up to early 90s. And if you read the old books, sometimes up to 40 to 50% mortality, surgical mortality we're talking about. But it has improved and definitely come down to less than 10% in most of the cases where it's done. In our center here in Medina, we had about 5%. We did about 18 patients so far in the last 5 years. We lost one patient, I think. Most important thing is, well, the surgical, taking care of the surgical details is one thing, but taking care of the patient doesn't stop there. Most of the patient is taken care of in the, especially these type of patients, in the intensive care. So what has improved in the last, let's say 15, 20 years, hardly very little in the surgical technique. Surgical technique has maybe slightly improved, but mostly it has improved in the ICU management and management of the pulmonary hypertension. Now we recognize the importance of it. We have tools to deal with it. We have nitric oxide, milrinone, whatever, keep them sedated. Uh, all the ICU management which you do, and then we have another tool of ECMO. If it's still not behaving, you can put them on ECMO for a few days and wait for the pulmonary hypertension to reduce so that they can be taken off. And this was proved by a multivariate analysis in which the two risk factors which stand alone for the early mortality is the pulmonary venous obstruction, which obviously contributes to the pulmonary hypertension in a more aggressive way, and single ventricle anatomy. Now, TAPVC, like most of the cardiac lesions, congenital cardiac lesions, as you realize, uh, they can be associated with lots of other things. And if there's a single ventricle anatomy associated with it, then their outcome is poor, early as well as late. But overall, in the long term, about 88%, there's one paper saying 88% survived up to 18 years, which is not bad considering everything. And I think it will improve with the passage of time. Even now, things like bosentan and other oral medications for treating pulmonary hypertension for the longer periods of time in a safe way will contribute to their better outcomes, I think. Now, how many of them will remain good forever? I think, again, in the literature it says 87% after a long term, and 13% of them two things will happen to them in the long term survivors. One is pulmonary venous stenosis, and they may require reintervention. And the reintervention could be a catheter-based intervention or surgical reintervention. And arrhythmias in the long term, one of the German study, they looked at some survivors, I think about 25 survivors who survived more than 15 years, and they did the Holters, and they were surprised to find atrial and ventricular arrhythmias in 50% of them. So yeah, arrhythmias can kill them in the long term. So I think this becomes important when we are talking to the parents if they want to know what will happen in the long term. Yeah, if the surgery goes fine and the baby is discharged and we follow him up, yeah, he's like normal person. Everything is good. But add this but that he needs regular follow-up for the rest of his life. And it could be even 18, 20 years later. Now this, with my personal experience, we have been in the business for a few years. It's very painful that you repair or do something to a baby or neonate and then he dies when he's 18-year-old. That's devastating, a normal person. So I think, to my mind, I would suggest to all the younger generation that when you read the long terms and the natural history, they add to your wisdom of so-called informed surgical consent. So you can have real information with them. And this
Reasonable
arrhythmia,
expectations.
sorry?
Like more reasonable expectations for
Yes,
the
because
future.
because you see the parents are not doctors most of the time. They may not be illiterate as well, and they will not know that the baby is fine. I can share with you a personal story of one of my very close friend who's a doctor. His son was a single ventricle and a very bright boy, and he went through all the 3-4 stages up to Fontan. He was tricuspid atresia, and at the age of 18 years, trust me, he used to play hockey, field hockey, if you know the field hockey in Pakistan. And he was the best graduate in his high school. And he suddenly developed SVT, and within 3-4 days he died at the age of 18 years. So that's devastating, I think. Well, that was devastating to that family particularly, which I'm an eyewitness to. So that's my suggestion. Now we go to this fun part of this palliative stenting, because if somebody can do a palliative stenting for you in an obstructed TAPVD, he will at least save you the hassle of doing operating on a sick baby, on a baby which you have just put an ECMO, and all these issues. And recently we had like two publications. One is a small case series, and one a case report, both done here in both done by, actually all of them done by Mansoor, I think, Mansoor Materi, and they were recently published. Now, what I want, one of the patient data, because we had it on our system, I brought here for you to see. So this was an 8 days old, 3.9 kg, and within 24 hours of the birth, was cynosed. So he was not in our Medina Cardiac Center does not have an ER for the pediatrics, so they are seen in the Velada, in the maternity and children hospital. So obviously they saw a cyanose baby, could not maintain it, so they ventilated it. And then echo showed a TAPVC, which was infracardiac. But it was not only that. He was a double outlet right ventricle. He had bilateral SVCs. His situs inversus totalis, his structures were on the other side, as you can appreciate from the heart. The apex of the heart is on the right side. And there was a gradient of 20 millimeter in the common descending vein, which was going somewhere into the abdominal vein. So this was the echo presentation. And then he was presented to us as a surgical team. You want to be a hero and operate on him? And I said no. This was the CT angiogram. Why I said no was also because we did not have ECMO at that time. So I did not have that much support. So, and the CT angio, you can see very nice images. Pulmonary veins joining a confluence which is going down below the diaphragm and seems to be obstructed here below the diaphragm. Remember, his liver is on this side, so the obstruction is going somewhere here. So he was taken to the cath lab, and this is the pulmonary artery angiogram, and you can see this. The same, similar to what you saw in the previous images, is going below, and somewhere here it's obstructed. Let me play it again. Pulmonary arterial injection goes to the venous phase and goes down. A conjoined one goes down here, and right. So the next was, this is the same thing with the introduction of a sheath. So you can see very nicely in the venous phase, all the pulmonary veins joining a confluence here. The confluence is going down below the diaphragm, and then seems to be stopping there. And that's why the baby was in such a bad shape. So he was stented in the cath lab, and this is the result. This is in the IVC, and you can see the injection is in the IVC and going up. And this is that hepatic vein connection, which is the blood flowing through it is giving you the impression that it is washed back. So the obstruction was relieved, and the obstruction was confirmed by at the time of the angiogram. Initially the mean gradient at the site of obstruction was 20 millimeter, and it got reduced to 6 millimeter. So the baby was brought back from the cath lab to the intensive care unit and managed there for a few days. But we noticed that he still has, now he started to develop a different type of problem with good PO2, but still difficult to wean from ventilation. And because he was a DORV in addition to the total anomalous pulmonary vein syndrome and a PDA. So 5 days after stenting, we took him for a PA band and PDA ligation. And after the surgical procedure, if you can, there's some clip here, whatever, where we did the PDA ligation and PA banding. And if you focus, or if I don't know if it's clear to you, you can see this big stent there in the infradiaphragmatic portion. Then he was extubated, and he spent a few days in the hospital because he needed some non-invasive ventilation and CPAP and feeding. And we discharged him to be corrected a few months later as an elective procedure. Thank you very much for your attention. If any questions, you are welcome.
Thank you very much for this practical and comprehensive lecture. It was really entertaining. Thank you very much.
جزاك الله خير.
Shabab, any questions?
Thank you very much.
No problem. No problem. Welcome.
Dr. So you said for the mixed type, so you can leave one of the veins if it's like really technically challenging to do it. Is there any long-term consequences for leaving one of the pulmonary veins?
No, you will find even in normal people sometimes that people who have no septal, nothing intracardiac, that one pulmonary vein is joining anomalously to the right side. Now, what is the consequence is a little bit more volume overload. Now, degree of cyanosis, they say it can contribute to 2 to 3%, but worst or 5%. So if his saturation is 95%, we don't need 100%. He lives okay. There's no long-term consequences of that. But yeah, if the one whole lung is going somewhere abnormally, then you have to find a solution to it.
السلام عليكم. I have a question for Dr. Aitizaz.
Yes.
السلام عليكم. Hi, Mufti from National Guard Jeddah. I enjoyed your presentation. Very nice. I just have a question. You said you don't ligate your vertical veins and superior TAPVC, and that's exactly what we were taught in Canada and Australia. But what about the inferior bridging vein in infracardiac TAPVC? Because the literature is all over the place. So in Melbourne, 2 surgeons ligate it all the time, and 2 surgeons say no, they can plug it in the cath lab. So what's your feeling? And I'm more towards ligating them. I don't like to keep them. But people say that, especially for infracardiac, you need some pop-off valve, although I don't see why.
I have always ligated the infracardiac ones as well. I mean, I cannot say that I've done so many, but at least 4 or 5, and I've ligated them and did not have a problem. And I think these vertical veins should be ligated. Now, the issue of the cath lab and whatever, obviously in a bigger center where the facility and the expertise is available, people can help you in the cath lab. But in certain situations, see a baby who has just been operated and he's still on ventilator, and you want to take him to the cath lab after 4 or 5 days with some other issues, to subject him to another big bolus of contrast and some vertical or descending vein manipulation in the cath lab. I think that's not worth the price. So yeah, I would go for venous ligation. Yeah.
Minimal manipulation for these children is better than
minimal manipulation, and try to tide them over, because they are very sick, as you know, especially the neonates and obstructed ones.
Yeah, and back to your point about putting them on ECMO and giving them time. So that was the regular practice in the Royal Children. We never took them emergently. We always put them on ECMO and leave them for 2-3 days, and then take them to ER after have settled down the storm and understood what's going on.
Yes, that's exactly what used to. I've seen a couple of cases in my training outside. I mean, in USA, I trained in Boston and Cincinnati for some time. So yeah, they had a very good ECMO setup, and as a cardiac surgeon, you just, even sometimes they would not call you to cannulate a baby who is not operated. It was a children's hospital, and the general pediatric boys will come and cannulate the child and put him on ECMO, and the ECMO team will deal with it. Now, this is not the ground reality here with us, and especially in the smaller places. The ECMO becomes a hassle in itself. So we don't see it as much here, but yeah, this is done, and this is an established way of doing it in a very sick way.
Yeah, but I think it's important for the residents to know that you don't have to take every single child who's obstructed to the OR just for repair. They have
No.
if they have ECMO, and then they should put them on ECMO and wait
Yeah.
to see what happens.
Yeah, yes, I would suggest to the younger generation and to the residents who are listening that think about everything. Don't just think of like taking the cat to
Because
the water.
operating on an obstructed child with a pH of 6.9 is a recipe for ECMO anyway after surgery.
Yes, yeah. So if he's that sick that he's about to die, then you support him with an ECMO and leave him for a day or two or something. Plan accordingly.
Yeah, and I have last question for you. So for your this nice case that you have a stent, what are you planning to do with the stent?
Now
That's a
this
problem for my experience.
yeah, this tent is a problem. It's hanging in the IVC. We I thought about it. I thought sometimes these tents we can see, let's say, go in the descending vein from open and look at the stent and try to tease it off. And if we cannot tease it off, I would cut it so that it can be expanded and leave it there, because I don't want a tear in the IVC at trying to do this type of repair.
Yeah, so my experience for when I was doing my training, they were at the phase of phasing out from stents because of an incident like that. They tried to repair it or
Yes.
extract it after 3 weeks, just 3 weeks, and they tore the IVC and they had a disaster.
Yeah.
The Royal Children, when I did my training in 2017, 18, they changed totally. So we just put them on ECMO and then take them to the OR because of that incident of stent tear.
Yeah.
Actually, they tried to pull the stent and they pulled the stent, and then when they finished the repair, there were massive bleeding in the abdomen.
Sure. And this area, IVC is very inaccessible with the livers.
Very inaccessible from the chest,
Yeah.
even from the abdomen. You have to lift the
Yeah,
liver.
yeah. Even a good general surgeon or derm surgeon will have problem.
Yeah.
So
So good
minimal
luck.
intervention.
I feel you. I feel your pain from now from operating on that child.
Yeah. Thank you. Any other questions, suggestions, doubts?
Yeah. My message for the residents: if your first case is a TAPVD, call for help. Call
Yeah,
for help.
well, I think that
Never do it by yourself.
that's true. That is true. That is true.
Any questions, Shabab?